I think we should start now. Yeah.
Hello.
We
Should we
can
start?
start now. Yeah, it's 3:05.
Okay.
We should.
Okay, ma'am. Good afternoon. It's a really privilege to welcome you for this learning session. Uh, Doctor is associated with Joka Cradle Fertility. She is there as the infertility specialist. So, ma'am, can you take your topic and start your session?
Okay. So good afternoon, everyone. So today's topic for discussion is the poor ovarian reserve. So poor ovarian reserve and diminished ovarian reserve is one of the challenging thing for an ART specialist to treat with. In our infertility clinic, around 9 to 25% of people with infertility diagnosed with the decreased ovarian reserve. So in today's topic, we will discussing about the poor ovarian reserve, what is the poor ovarian reserve, how it can be diagnosed, and what is the mechanism and etiology behind the diminished ovarian reserve, and what can be the possible management and how we can cope up with this situation. So first of all, what is an ovarian reserve? So we can define the ovarian reserve as the reproductive potential of a woman at a given point of a time. Ovarian reserve defined as quantity and the quality of ovarian primordial follicular pool. So if the woman is having a adequate amount of quantity and the quality of the ovarian follicle, this is called a normal
Madam,
ovarian reserve.
sorry to
And
disturb you.
yeah,
Your slide is moving little bit more, ma'am. Can you adjust that?
is it okay? No.
No. It's half of others and half of.
Okay. Is it okay now?
No, it is okay.
Okay. So poor ovarian reserve, it can be defined as reduction in the quantity and the quality of the ovarian follicular womb of a given point of time as compared to the normal woman. So if a woman is having the lesser quantity or the diminished quantity of the follicular pool as compared to the woman of the same age, she is being labeled and diagnosed as having a diminished ovarian reserve. There is a no universally accepted or definition for this, and approximately 10% of the women undergoing IVF will show the poor ovarian response to gonadotropin stimulation. So these women who are having the decreased ovarian reserve or a diminished ovarian reserve, they are a candidate of a poor ovarian response, and they do not respond well with the gonadotropin stimulation. So this is an important aspect on infertility clinic with women who present with diminished ovarian reserve, and this is one of the challenging topic or challenging thing to be treated by to be treated. According to American Society of Reproductive Medicine, the ovarian reserve is defined as maybe a number in the quantity of the remaining follicle and inside in both the ovaries at a given age. And diminished ovarian reserve is loss of normal reproductive potential in the ovaries due to the lower count and the quality of the remaining eggs. So these women who are having the decreased ovarian reserve, they are less likely to conceive, and they have an increased pregnancy loss or a decreased clinical pregnancy rate. So they are having a decreased reproductive potential as compared to the normal women of their age, and that's why it is now they have a lesser time or lesser window for the conception. There is another thing which is called the poor ovarian response. These two terms are two different terms. Poor ovarian response is defined as the inadequate follicular response to the maximum stimulation during an IVF procedure. So women who is designated as diminished ovarian reserve are likely to have a poor ovarian response, but not all women who are having the uh, poor ovarian response is not likely to have a decreased ovarian reserve. So poor ovarian response defined as per Bologna criteria is advanced maternal age more than 40 or any other risk factor for poor ovarian response, previous poor ovarian response, oocyte with conventional stimulation of more than 149 international unit FHS daily, and abnormal ovarian reserve test AFC is less than 5 to 7 or AMH is less than 0.5 and 1.5 nanogram per ml. If any of two in three criteria is present, the woman is defined as poor ovarian responder or poor responder. So this is Bologna criteria. If at least two of the three criteria to be fulfilled to be labeled as a woman of a poor responder. Poor ovarian reserve, the phenomenon noted in the woman in mid to late 30s, escalated decline in the follicular pool at the age of 37 to 38. It reaches below the critical level of 25,000. Subsequently, very limited time for the conception with one's own eggs accompanied by the decline in quality due to the aging oocyte. Poor ovarian reserve may be associated with lower pregnancy rate irrespective of age, and high pregnancy loss is there. So a woman is always born with a finite number of the oocyte, and that is to be 6 to 7 million at the gestation of age of 20 weeks. And when she is born, their oocyte quantity is 1 to 2 million at the time of the birth. At the menarche, she is having the oocytes of 3 lakhs. And at the menopause, these number is reduced critically. So there is an accelerated decline of the follicular pool when the woman reaches above the 35 years of age. So how do we diagnose or how do we test about the ovarian reserve of a woman? So ovarian reserve testing can be categorized is clinical testing, biochemical markers, radiological marker, and the dynamic test. So there are baskets of tests are present with to test the ovarian reserve, but till now there is no single test or ideal test which can accurately diagnose the ovarian reserve. So these are the biomarkers, elevated basal FHS level, antral follicle count 5, an anti-mullerian hormone 0.5 to 1.9, low peak estradiol concentration following the conventional ovarian stimulation. So till past 30 years, the test for ovarian reserve came up like this. Day 3 FHS level in 1998, clomiphene citrine challenge test in 1989, gonadotropin agonist challenge test in 1989, and then come up the inhibin 1997, and then recently the antral follicle count or anti-mullerian hormone in 2002. So here is the comparison of the test for ovarian reserve. Generally, we combination of tests are used to test the ovarian reserve because there is no single test which is ideal or accurate to diagnose the ovarian reserve. The basal FHS level, AFC count, and MH level generally clinician do. Here is the comparison between these three. So timing basal FLS level is measured on initial earlier follicular phase between day 2 to day 5 of menstrual cycle. Similarly, AFC is also measured by the TVS ultrasound on day 2 to day 5 of the menstrual cycle, and AMH has the advantage that it can be measured at any time of the cycles. Temporary changes indicating the ovarian aging. The basal FHS level is latest to increased as the ovarian reserve is decreased. And FC count is earliest one, and AMH is all the earliest one. So basal FS level has a intracyclic or intercycle variability, and AFC is very much dependent on the observer, and there is a minimum variability with AMH level. Advantage of basal FHS level that it is widespread would indicate AFC immediate result, good predictive value for the stimulation, ovarian response, including predicting the OHSS. AMH is reliable, high sensitivity, good predictive value for stimulation, ovarian response, including the predicting the OHSS. The limitation for basal FHS is that low sensitivity dependent on the functional HPO axis, less precision due to the intercyclic or intracyclic variability, and does not predict the OHSS. AFC count is have a inter-observer variability and require cost of ultrasound technician availability of ultrasound, and significant intercyclic variation in overweight or obese women. AMH level, the lack of international standardization assay requires the careful sample preparation and storage if ELISA being used. So the cutoff value for these ovarian reserve testing is that if FHS level is for 10 to 12 international unit per ml, if FC count is below 3 to 4 follicles per total in both ovaries, then it is designated a decreased ovarian reserve, and AMH level is less than 0.12 0.03 nanogram per ml. Now come to which ovarian test to be chosen. So as I said, there is no single reliable or ideal test for ovarian reserve. We use generally the combination of tests, which is more commonly used test is the basal FHS level, AFC count, AMH, and day 2 estradiol level. A large body of evidence has demonstrated the greater clinical value of AMH and AFC compared to FHS. AMH and AFC have often been considered interchangeable biomarker for prediction of the ovarian response. 4 recent large prospective multicentric trial in IVF intracytoplasmic sperm injection patient consistently concluded that AMH was a better predictor for number of oocyte retrieved as well as categorization of low and high responder than the AFC. So generally, two of these, AMH and AFC, are generally used to categorize the patient. Now used in clinical practice. AMH less than 0.5 nanogram per ml predicts the poor ovarian response in IVF with yield of 4 or less oocyte. In such cases, the discussion with patient about the short window of opportunity to conceive seems warranted. Ovarian stimulation protocol in these patients should include those designed to maximize follicular recruitment. So those patients who are having the AMH less than 0.5 nanogram per ml designated as having a diminished ovarian reserve, and these patients are the likely candidate of going to IVF and with the high dose of antagonist protocol. AMH more than 1 nanogram per ml but less than 3.5 nanogram per ml if the age appropriate consistent with normal ovarian response to ovarian stimulation. IVF protocol for these patients include standard GnRH agonist or antagonist adjustment based on the age specific value. And if AMH value is more than 3.5 nanogram per ml, predicts the hyper response to ovarian stimulation and is associated with significantly higher risk of going to the ovarian hyperstimulation. So what is the cause behind this poor ovarian reserve? There are basically follicular atresia, age-related or decline in the follicular pool, endometrioma, genital tuberculosis, or some other pelvic infection, and ethnicity and genetics are behind this decreased ovarian reserve. Now come to the follicular atresia. As I said earlier, the woman is born with a finite number of the follicular pool. There is a regular atresia of the follicle, and it is a continuous process as the woman gets older. 6 to 7 million of oocyte or follicular pool are present at the gestation age of 20 weeks, and these numbers are finite. As the woman gets older, the oocyte follicular pool atresia and decline in the oocyte follicular pool is a continuous process. Irreversible attrition from mid-gestation onwards and throughout the reproductive life diminish the germ cell pool of the gonads. Women experience a biphasic exponential decline in the ovarian follicle, a slow decay from birth to till 38 of age with an escalated decline thereafter. So as the woman gets older than 35 or 38 years of age, there is an accelerated decline in the follicular pool. Recent evidence challenges this view and suggests that decline is due to progressively increased rate of atresia throughout the reproductive periods. So here we can see that as the woman gets older, there is the atresia of the follicle and the diminishing the follicular pool. Now the non-growing follicle. There is a difference in size of the non-growing follicular pool between the women. The difference in size of the follicular pool in normal ovarian reserve can be as high as 100-fold when compared to those with poor ovarian reserve given the same age. So if there is a difference in size of a non-growing follicle, the woman who has a normal ovarian reserve has a good non-growing follicular pool as compared to the women who are having a diminished follicular pool. Lacks clarity if this is due to difference in the size of initial follicular pool or due to difference in the rate of the depletion. The available data suggests that the non-growing follicular at different age may have a differing response to changes in the hormone levels associated with age. Natural age-related decline. Many events and conditions depletes the ovarian reserve, like lifestyle and environmental changes, like chronic smoking, obesities, and pelvic infection like genital tuberculosis, ovarian surgeries, radiotherapy, and chemotherapy. These are the factors which decreases the ovarian reserve and harms the ovarian tissue. Impairment of intrafollicular, endocrine, and other regulatory mechanism. Reduced aromatase activity, reduced biological activities of gonadotropin surge, and altered blood flow are the reason behind this diminished ovarian reserve. Now comes to the endometriosis. Endometriosis is one disease which eats up the normal ovarian tissue, and the women with endometriosis generally have a decreased ovarian reserve. It affects the internal milieu and local environment. Surgical excision of endometrium are also known to cause the poor ovarian reserve. Mechanism behind this is mechanical pressure on the ovarian cortex, impaired vascular networks, and attrition of the cortical stroma. So endometriosis or the decreases the ovarian reserve because it eats up the normal ovarian tissue, and the women with endometriosis generally have a decreased ovarian reserve. Now come to the pelvic infection. Genital tuberculosis is one of the commonest in pelvic infection in the developing countries like India. Genital tuberculosis, even in its latent form, is known to cause the poor ovarian reserve. Abnormal ovarian reserve testing and shows the sign of the poor response. Requiring a high dose of gonadotropins during the stimulation and reduced oocyte yield. Mechanism involved in absence of ovarian obvious structural damage is unclear. Now come to the ethnicities. So women of certain ethnicities are known to have a decreased ovarian reserve as determined by the ovarian reserve marker. Like the women from the India and Southeast Asia is comparably 6 years older than their Spanish counterparts. Those from India, Southeast Asia, Middle East Asia, Afro-Caribbean undergoing IVF in UK showed a lower live birth rate when compared to the white women. Similarly, China, Latina, African women had a lower ovarian reserve compared to the Caucasian women of a similar age. There is some genetic correlation with the diminished ovarian reserve, altered expression of the certain gene in cumulus and granulosa cell associated with diminished ovarian reserve. Mutation, polymorphism, altered splice variant in FHS receptor have varied effects on the receptor structure and function. Mutation in FMR gene are known to be associated. Mutation in MRC leads to the premature ovarian failure, and certain syndrome like Turner syndrome, Fragile X syndrome are known to cause diminished ovarian reserve. So to summarize this, the possible causes for diminished ovarian reserve is family history of early menopause, certain ovarian surgeries like for chocolate cyst and other pelvic infection, and gonadotoxic therapies like radiotherapies, chemotherapies, autoimmune diseases, and some environmental or lifestyle factors. So these are the possible causes behind the diminished ovarian reserve. Now come to the management and implications. So as I have said earlier, that these patients have a shorter time to conceive, shorter window of to conceive, and there is a need for aggressive treatment if they want to conceive with their own oocyte. So they are likely candidate for IVF or in vitro fertilization. Now, pre-treatment with the oral contraceptive, progesterone, ethylene estradiol. So these women are generally pre-treated with oral contraceptive pills and ethylene estradiol to synchronization of the follicular growth and to rescheduling of the ART cycles. No difference is noted in pregnancy rates, but increased flexibility of the IVF cycle. Pre-treatment with OCP increases the duration of the stimulation. So here is the treatment regime for the patient with decreased ovarian reserve. First is the high dose gonadotropins. Generally, the starting dose is 300 to 450 international per day, along with addition of the LH, HMG, or the low dose supplement with SCG. 100 to 200 international per unit. And there are protocol like GNR agonist protocol, where short agonist protocol, microdose flare protocol, ultra short protocol, long agonist protocol, all can be used. There is antagonist protocol with fixed multiple doses or flexible multiple doses, and with natural cycle or minimal cycle stimulation, natural cycle, modified natural cycle, minimal stimulation with oral evolution, and with FHS. And some adjuvants are there which show some shows some improvement in number of the follicular pool if they are treated, if they are started before 3 months of the starting of the ART cycles. Now come to the control ovarian stimulation for IVF in poor ovarian reserve patient. Stimulation with high dose of follicular stimulating hormone like 300 to 450 international per unit to maximize the oocyte yield is commonly used protocol for this kind of a patient. So starting dose is 300 to 450 international per unit. And with addition of LH in early follicular phase may have some beneficial effect on oocyte, hence the embryo quality. However, the available evidence regarding the addition of the recombinant LH to FHS is inconclusive. So the high dose intake is started to maximize the oocyte yield and to maximize the response of these. And addition of the low dose SCG supplement or addition of the pure HMG, where SCG is the source of LH activity, has shown some improvement in the oocyte yield or oocyte quality. Luteal start of FHS has been used to influence the recruitment of the follicle without any reported clinical benefit. So here is the high dose gonadotropin regimen. The drawback of high dose gonadotropin is that there is a poor oocyte quality, patient discomfort, and gonadotropin association side effects. So, and financial burden also. The woman has to take a very high doses of gonadotropins, and this leads to the financial burden with these. Ovarian control stimulation protocol is stimulating with the high dose of FHS. FHS plus RLS, the available evidence regarding the addition of recombinant LH to FHS is inconclusive. So there are, if we add the recombinant LH, the evidence is inconclusive. If with the FHS, the SCG or HMG is used, the low dose SCG supplement or addition of the pure HMG has shown some improvement in the oocyte yield. So here is the comparison between the GRH agonist and the antagonist protocol. Pituitary desensitization with prolonged daily administration of GRNH agonist long protocol. Long GRNH agonist treatment is perhaps still the approach of choice. GRNH antagonists are, however, associated with a lower ongoing pregnancy rate when compared to the agonist protocol. So there is no superiority of any protocol with others. Anything can be used, like high dose antagonist protocol can be used, or a agonist protocol can be used. In agonist protocol, in long agonist protocol, the treatment duration is generally high, and many injection has to be taken, and gonadotropin. And with short agonist protocol, there is a shorter time, and the agonist is started in the early follicular phase along with the gonadotropins. And with flare protocol or flare agonist protocol, the very low dose, around 50 to 100 microgram agonist is used, and it uses the endogenous gonadotropins to stimulate or to recruit the follicles. Now, this is the comparison between GNR agonist and antagonist protocols. GNR agonist protocol, the long agonist protocol increases the duration of treatment and low total dose of gonadotropin necessary to effect the follicular development in the poor responder. Agonists, due to their initial flare effect, may help in recruitment of the follicle. Short agonist protocol, where agonist administration is initiated in early follicular phase before gonadotropin administration, is one of the most widely used agonist protocol in poor responders. And here again, the microdose flare or ultra short protocol are preferred by some clinicians to minimize the pituitary suppression, but have not shown to improve the clinical outcome. So here we can see in long agonist protocol, we start the agonist from day 21 of the previous cycles, and then gonadotropins are initiated. But in short agonist protocol, the agonists and gonadotropins are started with the early follicular phase. But in flare protocol, a very minimal dose of agonist is used, that is between 50 to 100 microgram, and this uses to suppress the pituitary suppression. Here is the GNR agonist and antagonist protocol. Antagonist protocol provides an effective way to prevent the premature LS surge without prolonging the treatment duration. So in antagonist protocol, the treatment duration is shorter, and women has to take the lesser number of the gonadotropins injection as compared to the agonist protocol. And here the antagonist is used to suppress the premature LS surge by the pituitaries. So it is now a preferred treatment than the agonist protocols. Pregnancy rate achieved are similar to short agonist protocol. So antagonist increasingly use shorter duration, less exposure to gonadotropins, as these antagonist protocols are shorter duration, and so women are more compliant with these protocols. So provided an effective way of preventing LS surge without prolonging the treatment duration. Pregnancy rate achieved are similar to short agonist protocol. So natural cycle or the minimal stimulation. The idea behind this is that when we use the very high dose of gonadotropins to maximize the oocyte yield, the quality of oocyte is decreased, where these newer protocol like natural cycle, modified natural cycle, or minimal stimulation protocol increases the oocyte quality, but there are some disadvantage also. Like alternative to high dose regimen to reduce the gonadotropins burden, with possible improvement in oocyte quality to reduce the financial burden of the high dose regimen. And with modified natural cycle with IVF addition of antagonists and very small dose of FHS. So we can do with this stimulation with natural cycle, modified natural cycle, minimal stimulation. In modified natural cycle, what we do is we use the antagonist along with some small doses of the follicular stimulating hormone. Alternatively, with minimal stimulation, what we do, we use the oral ovulogen like letrozole and clomiphene citrate along with the small doses of the gonadotropins with antagonist. Cancellation rate is higher in these cycles. Around 50% of the cancellation rate is there. Pregnancy rate has been reported to be as high as 8 to 18%. Alternative for poor responder which is when more widely used high dose FHS protocols is unsuccessful. So when the high dose antagonist protocol or high dose gonadotropins will fail, we can shift the patient to the modified natural or the minimal stimulation protocol, which generally increases the oocyte qualities. Now, what is the disadvantage for these natural or minimal stimulation protocol? There is an abnormal follicular maturation and premature ovulation of a single follicle, so we can lose the oocyte. There is a failed fertilization, failed oocyte retrieval, or empty follicle at the retrieval. So natural or minimal stimulation is associated with high risk of cancellation due to these reasons. Now come to the adjuvant therapies. These adjuvants are supposed to increase the ovarian reserves if they are given before 3 months or 2 months before the starting of the stimulation. So androgen are used as an adjuvant in patients with decreased ovarian reserve. The idea behind using the androgen is that these androgen convert the pre-enteral follicle to antral follicle, and these antral follicles are sensitive to gonadotropins. So these pre-enteral follicles are sensitive to androgens. So these androgens are used to convert these pre-enteral follicle to antral follicles. So androgen supplement in form of the oral dihydroepiandrosterone or transdermal testosterone is used, and poor responder, and is believed to improve the intrafollicular environment and the follicular sensitivity to gonadotropins. And another adjuvant which can be used as is growth hormone supplementation. The use of growth hormone supplementation has been shown to increase the clinical pregnancy rate and the live birth rates. Growth hormone supplementation is another adjuvant therapy which can be used in patients who are having the diminished ovarian reserve in combination with controlled ovarian stimulation to improve the oocyte yield and pregnancy rate in the poor responder. The aspirin. Aspirin is supposed to increase the blood flow of ovary and thus increases the delivery of the gonadotropins to the follicles. The good intra-ovarian blood flow is believed to improve the delivery of gonadotropins hormone for follicular genesis, and poor ovarian blood flow is linked to the poor ovarian response. So there is insufficient data to support the beneficial role of use of growth hormone, aspirin, and dihydrogenase as an adjunctive therapy. So these adjuvants can be used in patients who are having the diminished ovarian reserve to somewhat extend their ovarian reserve before starting the IVF cycle or ART cycles. Now to summarize these things, poor ovarian reserve is the reduction of the quality and the quantity of the follicular pool of a woman of a reproductive age group. So it is basically a decreased reproductive potential of a woman at a given age. The biomarker or ovarian reserve testing which is generally used by the clinician, are the interfollicular count, AMH hormone, elevated basal FSH level, and the low peak estradiol concentration after the ovarian stimulation. So etiology or the causes behind this is the follicular atresia or accelerated decline in the follicular pool and some ovarian surgery, ovarian injury, gonadotoxic therapy like chemoradiation, radiotherapy, and some genetics and ethnic reason are there.
Hello.
Yes, actually, there is some power issue. Just
Uh-huh.
within few seconds, she will be online.
Okay.
Share content. Okay. Yes, now I would like to summarize this topic. So, poor ovarian reserve is decreased or diminished quantity and the quality of the follicular pool, and it is can be defined as the reduced reproductive potential of a woman at a given age group. So, how do we diagnose this? There are some ovarian reserve testing is there, and generally commonly used test is there. Interfollicular count, AMH level, and basal FHS level. Poor ovarian reserve can be defined as reduction in the quantity and the quality of the ovarian follicular pool. So it is a reduced potential, reproductive potential of a woman at a given age group. And what are the tests available for these testing for the ovarian reserve? There is a no single test, as I said earlier, to accurately diagnose the ovarian reserve, and combination of tests used, and most commonly used tests are interfollicular count, anti-mullerian hormone, elevated basal FHS level, and low is peak estradiol level after the ovarian stimulation. So what can be the reason behind this diminished ovarian reserve is the follicular atresia, escalated follicular depletion, and some infection like genital tuberculosis, other pelvic infection, cancer, chemotherapy, and radiotherapy, which are gonadotoxic, endometriomas, and some ethnic and the genetic genes behind this diminished ovarian reserve. So there is no uniformly accepted definition or a criteria to define a poor responder. So Bologna clinical criteria is used to define a poor ovarian responder. So this is the Bologna criteria which came to define the poor ovarian responder, and any two of these three should be present to stamp a case as a poor ovarian responder. And management, as I said earlier, there is no management which is superior than the other. We can use both agonist protocol, antagonist protocol, natural cycle, and minimal stimulation or modified natural cycle can be used. The disadvantage for the agonist protocol is that it is a long duration protocol, and many of the gonadotropin injection are used. With the antagonist protocol, high dose antagonist are high dose gonadotropin is used to maximize the oocyte yield, or but the quality of oocyte is decreased with these higher dose of gonadotropin. So the idea came with natural cycle or the modified natural cycles. And this, but there are disadvantage of these protocols also. There is a high cancellation rate, and we can lose our oocyte. And lastly, some adjuvants are used to increases these ovarian reserve, which are androgens, growth hormone, or aspirin, which has a no beneficial role, no evidence of beneficial. Yes, that's done.
I think it's the end of your presentation, doctor.
Yeah.
Yeah, thank you.
Summarize
Thanks
the case.
Yeah, thanks for your valuable insight on poor ovarian reserve. Can I ask viewers regarding if they have any questions regarding this? From viewer side, if you have any question regarding this topic, you can ask to doctor. You can unmute yourself and ask the question, or you can put your question in chat box. Is there any question regarding this topic? I think there is no question.
Okay. Okay, so let's.
Thank you. Thanks for
Okay,
your.
thanks everyone.
Yeah, thank you.